My name is Catherine Vandenbush. I'm one of the faculty members for the TASN Fellowship Program, and I'm going to start us off today. So I just really wanted to start by welcoming everybody today and really thanking everybody for all the work that everybody has put in, whether it's the fellows or the mentors or the faculty. This has been an amazing program so far, and I'm really excited that the fellows are going to get to present where they've done. Rue Tagger, who is our VP, Chief Nursing and Health Professions, Quality and Patient Safety, and Lisa Di Prospero, who is our Director of Practice-Based Research and Innovation, both send their regrets today. They look forward to watching this after today, but they have other commitments they both couldn't get out of. So for those of you who don't know, the TASN Fellowship Program is a program where frontline clinicians, supportive care clinicians, actually apply with a project, a quality improvement project, and they have some dedicated time set aside over the course of 6-7 months to specifically working on this QI project. So we are actually about 2.5 months into this sort of 6-7 month project. And so looking forward to sharing with you what we have so far. So here at Sunnybrook, we're really committed to, again, improving quality of care. And we're really excited that, again, the fellows are coming from that frontline experience. So they're bringing their knowledge and skills of what they see every day and opportunities to improve the way we can deliver care and provide care in really unique and innovative ways. So coming from frontline. Our frontline clinicians, again, I'm looking at our fellows, are really going to make an incredible, unique contribution to the way we deliver care. So I think you guys should be very, very proud of yourself for what you're doing thus far. And so far, as a faculty member, I've been really committed and really impressed with the ideas of the projects that have come forward, the advancement from where the projects started in a very short period of time, the collaborative learning that's happened in a short period of time, and I'm really excited to see where things are going and how they're going to move forward and actually change that care. So again, although we're only at midpoint so we're calling it midpoint in the projects and in the program, things are pretty exciting. So I don't want to do all the talking, so I would like to pass it over to our first presenter, so Grace Brzezinyak, who is a pharmacist here at Sunnybrook, to share with you her project, her quality improvement project thus far. Great. So Grace.
Great. Thank you. Thank you so much. Good morning. Thank you for the opportunity to provide an introduction and some insight into my project thus far. So as was said, I am a pharmacist and I work in internal medicine. And I'm really, really excited to be taking part in this practice-based research and innovation fellowship this year. So this phrase, if it wasn't documented, it wasn't done, is probably something you as a healthcare provider have either said, heard, or thought about during your career. And for those of you who are not familiar with the phrase, it means that if there's not a record of the care you delivered in the patient's chart by the way of documentation, the activity itself wasn't done. And while this statement makes sense at face value, when placed in the context of patient care delivery, the statement has more extensive implications as healthcare organizations transition from a paper-based record keeping to an electronic health record. And this statement is really the drive of my project, because even though this internet meme suggests otherwise, that we don't actually do much work. No, I'm just kidding. Hospital pharmacists contribute a great deal to the care that is provided to patients while in hospital. I'd like to think that we do a little bit more than just sitting behind a computer desk, but our responsibilities do differ than what is traditionally seen as a pharmacist. In addition to being responsible for delivery of drug product, we are on the front line in terms of assessing we are in the front line in terms of working with patients to ensure that they're taking their medications appropriately, counseling on new medications, and working with physicians and nurses to provide recommendations and information about the effectiveness and appropriateness of medication regimens. And yet we're not like your typical allied health provider. We're not consulted upon. So as long as the patient is prescribed a medication, we're involved in the patient's care. And so we sort of become these detectives in terms of going through the patient's chart, going through their medication regimen, and trying to assess, going through their labs, going through diagnostic tests and so forth, and trying to assess really whether their therapeutic plan is the most appropriate. And it's not always, and it's not always been reflective in clinical documentation. So the evolution of pharmacy, it sort of began where we were sort of the provider of medications. We were previously very task or product oriented, where we were documentation itself was really, it was a check off that the prescription was signed off, maybe a little note that counseling was provided, but there wasn't much more. And as the profession evolved and expanded, where we became more integral in identifying, resolving, and preventing drug therapy problems, this documentation has really followed suit. So while the standards of documentation have been there by the regulatory bodies like the College of Pharmacists, it really hasn't flown in terms of the curriculum or what we see our preceptors doing as well. So with the combination of everything that we do in terms of drug dispensing, order entry, and all our other responsibilities, documentation has kind of been on the wayside, and there are gaps between proposed standards and current practice in terms of documentation. There are benefits to pharmacists who document, obviously creating a permanent record of drug therapy rationale, communicating with other healthcare professionals, demonstrating the level of care that we're providing to patients, facilitating seamless care, especially as patients transition between hospitals, workload measurement, amongst others. But there are challenges that arise that prevent patients from achieving professional responsibility. And they include some time constraints, dispensing responsibilities, confidence of the pharmacist to take accountability for their recommendations and patient caseload. So Sunnybrook has implemented electronic documentation for clinical pharmacists since February of 2017. SunnyCare is our own curated version of an electronic health record. It's a digital version of a paper chart that contains all the patient's relevant medication history on site. And while the rollout happened without any change in practice in terms of any additional education or support, and so since we're still in the early stages, it's important to collect the perspective of pharmacists to implement practice change strategies to make it meaningful for both the pharmacists and the end users. And so by understanding the barriers and facilitators to attaining best practice with respect to documentation, we can discern the attitudes of pharmacists towards documentation, and based on the information that we've gathered from them and the various stakeholders as well, we can propose some interventions to facilitate integration of documentation into pharmacists' daily practice. For example, such we can try to influence templates in the clinical documentation system being developed for use in Sunnybrook. And we can also impact the patient itself. We can provide some benefits. So here at Sunnybrook, we have an e-health service called MyChart, which is, it helps to streamline the way that health record information is accessed and shared. Sunnybrook recognizes that patients are key stakeholders in the delivery of care, and the service empowers them to manage their health by putting the necessary information in their hands. So a lot of information is provided to patients during their stay here in hospital, and a lot of the times the information is forgotten or misunderstood. So by having pharmacists document their therapeutic plan, including rationale for drug therapy and counseling points, it can provide an additional source for patients that they can understand, they can access from home to understand and manage their medications. So the goal of this project is to gain insight into the pharmacist's attitudes towards documentation, the barriers they encounter with documentation in order to inform strategies to improve and facilitate integration of electronic health record documentation to daily practice. So these are my objectives. Essentially, I'm just going to try to understand the current practice of documentation, including the frequency of which pharmacists will document, where the documentation occurs, and the type of information documented, determine their baseline knowledge of OCP standards, use the information gathered from baseline data to design and implement a documentation workshop, and measure any change in practice. So currently my project status, I'm in the program planning part. So as I'm awaiting REB approval, I've completed a literature review. I've drafted semi-structured interview questions for the interviews. I've engaged and met with stakeholders, and I'm currently designing the education session. And so then the next steps are to, once I get REB approval, I'll use semi-structured interviews. I'll invite clinical pharmacists in acute care with direct patient responsibilities to participate in semi-structured interviews. I am aiming to target about 15 pharmacists using purposeful sampling. And the study participants I'm going to hope to choose will hopefully best illustrate a range of beliefs and experiences relevant to clinical documentation. From there, an online survey will be disseminated to a broader population of acute care pharmacists, so hopefully about 30 pharmacists, to verify the themes that were emerged in the interviews. And then there'll also be a needs assessment component to inquire what support the pharmacists require. And then I'll conduct a workshop, maybe 2 or 3, to cover all of the pharmacists or any pharmacists interested in participating. And it'll be designed using adult learning principles and incorporate active learning strategies. The curriculum itself will be based on audit data, literature review, survey results, semi-structured interview feedback, and stakeholder input. And the workshop primarily will focus on applying guidelines from the college, from the Ontario College of Pharmacists. And then throughout, I'll measure change like before the workshop and change in practice, whether there is any change in practice after the workshop. And I'll also evaluate the workshop itself based on what the pharmacist's feedback. So in conclusion, following the doctrine that the supply creates its own demand, as is displayed by the advent of the iPhone, which we never knew we needed, but now we seem to not be able to live without. Through routine, consistent effort, documentation of clinical activities and pharmaceutical opinion will become expected by other members of the interprofessional team. So if we continue to routinely document, others will see it, they'll use it, they'll expect it, and they'll value it. So with that, I'd like to just take a moment to acknowledge all the wonderful support I have received since the start of my fellowship. Everyone from Sunnybrook's practice-based research, innovation, Lisa Disprospero, Sarah Morase, Catherine, you guys saw my last name was hard, Catherine Van Bush and Jennifer Schaefer. the director of pharmacy who's provided funding for the Pharmacy Innovation Fellowship, Scott Walker, my mentor Artemis, Diamantouros, Margaret McCormack, the director of clinical documentation, and all my TASM fellows. Thank you so much. And I invite any questions. Great. Oh, please. Absolutely. No, not directly. We had thought about maybe providing a survey to patients to see what they would like to see from a pharmacist know, but we just want to keep it contained, so we're not. Great, thank you.
Okay, thanks, Grace. And, sure. So next, we'd like to call up Carolyn Aswad. And Carolyn, just a reminder to please repeat the question when you're taking questions so everyone can hear on the webcast.
Okay, hi, my name is Carolyn Aswad. I'm a nurse on the birthing unit here at Sunnybrook. My project is called Providing Breastfeeding Education and Support to Mothers and Families Who Do Not Speak English. So to begin, I would like you to imagine or remember when you had a baby, or maybe someone close to you had a baby, how stressful and overwhelming that was. And now imagine how that would feel if you had your baby in a place where you didn't speak the language. So at Sunnybrook, 1% to 2% of patients, or about 70 people per year, don't speak English or have a language barrier. So what we know about language barriers is that they present a significant barrier in the access to care and can lead to negative health outcomes for patients. And what we know about the healthcare providers who care for those patients is that they have a decreased level in the satisfaction of their care. What we know about breastfeeding is that breastfeeding provides better long and short-term health outcomes for both mom and baby. It facilitates bonding between mom and baby, and it is a cost-effective feeding option for babies. So we know that breastfeeding has the potential to counteract the negative health outcomes associated with language barriers, but we also know that the exclusive breastfeeding rate on discharge for women who don't speak English is significantly lower than for those patients who do speak English. So that is kind of what I'm looking at with my project. So we want to help women breastfeed. So we know that women who are well supported tend to breastfeed for longer. What we know about health literacy is that 40 to 80% of what we tell patients is forgotten immediately, and 50% of that is recalled incorrectly. So we need to have a lot of opportunities to kind of restate the same information over and over again. So at the Women and Babies program, we have a lot of opportunities to educate patients. We have our prenatal classes. We have the Women and Babies program website, which has information on it. We have a daily breastfeeding class for inpatients, which is led by a lactation consultant and a nurse. We have lactation consultants in the breastfeeding clinic who have outpatient breastfeeding appointments. They can also provide inpatient appointments on the day of discharge for patients who are having problems with breastfeeding. And we also have our lovely nurses who are constantly there at the bedside helping with breastfeeding, answering any questions that patients have. And we also provide written educational material on admission postpartum and on discharge. So we have a lot of great information and opportunities to educate patients. However, much of that information is only in English. So pretty much our main resources for patients who don't speak English are we have an interpreter phone service, which is currently kind of underused. And we often try to match up a healthcare provider who speaks another language with that patient who speaks that language. So we clearly do have a gap in the access to resources, and this presents the opportunity for change. So the aim with my project is for postpartum patients on our maternal newborn unit and birthing unit, I would like to increase the rate of exclusive breastfeeding on discharge by 10 percentage points. I would like to increase the opportunities for one-to-one extensive breastfeeding education with those patients. For the staff caring for these women, I would like to increase their comfort level of educating these women with breastfeeding, and I would also like to increase their level of satisfaction with their care of women who don't speak English, and to have this completed by March. So the changes that I've come up with to achieve these goals are to assemble and create breastfeeding resources translated into 6 languages, which would be French, Arabic, Spanish, Tamil, Chinese Simplified, and Farsi. I want to make translation boards available at the bedside in these languages, which would facilitate quick interactions between staff and patients. I want to make a breastfeeding education script, which nurses or other staff can use at the bedside to facilitate extensive breastfeeding education one-to-one. And then I need to educate staff about these resources and how to access them and use them. So the outcome measures that I'm going to use to decide if my project will have any effect are measuring the staff comfort of teaching breastfeeding of education or breastfeeding of patients who don't speak English, count how many patients receive one-to-one extensive breastfeeding education, measure the exclusive breastfeeding rate on discharge for these women, and rate the patient satisfaction of their breastfeeding. The process measures that I'm going to use include how many staff are trained on these interventions and how many non-English speaking patients receive these interventions. So I'm going to tell you now about what I've done so far. So how did I pick these languages? So I wanted to pick the languages that we see the most often in the Women and Babies program to kind of get the most number of women with this project that I'm doing. So first I looked at our hospital PCS data. I looked at our OBTV data, which is our Women and Babies obstetric charting system, and I used City of Toronto census data. So the PCS data from the hospital was not helpful because there is a language field, but it was either not filled out or it only said English. The OBTV data was quite helpful. However, the field where you can write where what language a patient speaks is not mandatory, so it's definitely possible and likely that we're not getting the full picture in the number of women who don't speak English. The City of Toronto census data was also quite helpful. It has information based on age, which is useful for our program because childbearing women tend to be younger, so getting that level of data was very helpful. There also was data on which language groups are growing in the GTA. So all this data in combination together gave me these languages. There's also, of note, the French Language Services Act, which requires that hospitals providing care are able to provide that care in French. So I'm also going to include French in the number of languages that I'm translating into, although we don't see that many French-speaking patients. It is also useful to know that the Ontario government provides support for translation into French, which is very handy for us working on a budget. So I've done a number of surveys and data collection. I've collected baseline data on our patients who don't speak English in OBTV. I am conducting ongoing patient interviews with the use of an interpreter phone to find out how they are breastfeeding their baby, how they decided they were going to, how they were going to feed their babies, how comfortable they are with breastfeeding, and if they have any suggestions for us on how to improve communication with them. I've completed staff surveys of nurses and lactation consultants to find how comfortable they are educating women about breastfeeding, what their level of satisfaction is with caring for women who don't speak English, and if they have any suggestions on what information to put on the translation boards that we're going to use at the bedside. And I'm currently in the process of surveying midwives, family practice doctors, nurse practitioners, pediatricians, and obstetricians to find out how they communicate with these women, and also if they have any suggestions on what to put on their translation boards. So the bedside translation boards, I haven't finished yet, but I'm in the process of doing them. So they're going to look like a combination of what you see here. So there's going to be English and a second language on the same translation board. It's going to include basic phrases and topics that we talk about most often postpartum at the bedside. I'm going to use the suggestions that I've gotten from all the staff and patients to include on these boards. There's a lot of educational material already available, which I think a lot of our staff don't know about. So we have a lot of really good high quality information coming from Best Start, Toronto Public Health, Ministry of Health and Long-Term Care, Ministry of Child and Youth Services, which is Ontario specific, and as I said, very high quality. So I am collecting that information and going to tell the staff about it, make sure they know how to access that stuff. So what I have here is on the left, a resource in English, and then on the right, the same resources in another language. So if we print out this material and give it to patients at the bedside, a nurse can look at the English resource, they know what's on there, and they can point to that same resource in another language. Even if the nurse doesn't speak that language, they know that the same information is there. So they can actually use this written material for educational purposes at the bedside. For stuff that is not available online, I'm going to collect that and have it translated. One of the educational materials that we give to patients on admission to the postpartum unit is the purple You and Your Baby, a Parent's Guidebook, which has a lot of information on self-care, breastfeeding, baby care. So a lot of that information is available online, but some of it isn't, so I'm going to have that translated. And I'm also going to translate some of our discharge information, which is not specifically related to breastfeeding, but if you can imagine someone is concerned about how their baby's doing, maybe they don't know when to go to the doctor, that might frustrate them and can impact their breastfeeding. So if you think in terms of kind of a holistic protection of breastfeeding, having this discharge information translated is important. So I'm going to do that as well. I have also applied for and received a patient and family education grant, which I'm going to use to help with translation and creation of these resources. So that's what I've done. The next steps for me are to finalize the written resources and translation board text and have it translated. I need to still create a guideline or script for nurses to use at the bedside for one-to-one breastfeeding education. And then later in the new year, I'm going to educate the staff on these resources and how to use them, how to access them. And then once I'm done that, I'm going to survey the staff and see if I have any measurable outcomes, hopefully positive ones. So that's it for me. I would like to say thank you to the fellowship for supporting me, giving me money to do this project, and the faculty for their great support and the great curriculum. The Patient and Family Education Grant for money to do part of my project. Sue Herman, my mentor, for all her support. Monica Nicholson, my manager, for her support, both emotional and financial, for my project. Jo Watson for her great support, and Marie Sanderson of Patient and Stakeholder Relations for her support as well. So does anyone have any questions? Yes. Mm-hmm. So the question was on the spectrum of knowledge of a language, how do we address that, I guess, is the question. Case finding. how do we define who doesn't speak English? That is a good question, and there is no really great definition. And I have found while talking to patients and nurses about patients who don't speak English that there is a broad spectrum of definitions. So one patient who someone says, a nurse will say, this patient does not speak English at all. The next nurse will say, oh yeah, she speaks English, that's fine. But I think the main thing we have to address as healthcare practitioners is find out what the patient needs herself, ask her what she needs. So if we have that patient who one nurse says she doesn't speak English, another nurse says she does speak English, ask her, do you feel comfortable with these materials in English? Would you like to have written materials in your own language? Sometimes a patient will say, oh yeah, English is fine. And sometimes they'll say, no, I actually would like to have this available in Mandarin. That would be really helpful. So there is no one solution fits all for our patients. We really have to get a kind of a patient-centered care perspective on caring for these patients. Yeah, so making these resources available for other family members is a really good idea. I think in the future, if this proves to be successful, I would like to present these materials to patients post or antenatally when they first see their obstetrician, so they have material to look over in their own language before they come to the hospital and then are suddenly inundated with a bunch of information. If they have time to kind of ruminate on information, I think they can make better decisions. Yes. Okay, so the first question was on if I've contacted other hospitals to see what they're doing. And yes, I have. So a lot of the hospitals are kind of doing what we do, which is just struggling at best. I think Trillium, the new hospital, has actually quite good resources. I think because the hospital is new, they have iPads on wheels that they use for face-to-face translators or interpreters. They also apparently have e-discharge summaries, which they just can apparently print off in other languages. However, I think that's a really large capital investment that we don't have access to right now at Sunnybrook. But there are some good, possibilities out there. But I think most hospitals are kind of struggling along with what we do, or similar to what we do. And sorry, what was your second question? Oh, discharge. So linking it up, discharge with family doctors or other healthcare resources. So all of our patients have the opportunity to be referred to Toronto Public Health. They have a really good program called Healthy Babies, Healthy Children, which provides support to families in the postpartum period. And that resource can actually be provided in any language. So we always make that referral for patients, and often if they're new to the city, they don't speak the language, they're very grateful for this resource. So we can refer them to that program. A public health nurse calls them within a few days of them going home, and then they can actually provide home visits as well. So we do have a good kind of like foot in the door in terms of public health care on that end. I think that's it for me, so thank you very much, everyone.
Thank you, Carolyn, and thanks for the great questions. Next, we'd like to ask Leanne Hogan to come up and present.
Good morning, everyone. My name is Leanne, and Hi everyone, my name's Leanne, and I work here at Sunnybrook in PBRI ICU, and my project involves engaging with families in the intensive care units to complete the family satisfaction survey. So today I'm going to share with you a brief overview of my project and some background information. I'll share with you what the current status is of my project, why my project is important, and what the next steps are on my project from now until March. So the critical care department launched the ICU website last year. It's called Navigating the ICU. And the website includes information for families. It includes a welcome video to the ICU, as well some information for families they can look up information about the ICU. There's some ICU links, as well commonly asked questions that they may have about the ICU. This website is actually designed specifically for families who have their family members in one of the ICUs here at Sunnybrook. So the website was created to share information that will help families understand what's happening in the ICU. It's also an opportunity for families to give feedback on the care that the ICU team is providing their loved ones who are in the ICU. As well, it's also a way for the healthcare team to engage with the families and help them feel that they're actually part of the team. My objective is to identify and address barriers that may keep families from completing the satisfaction survey in the ICU. As well, my aim is to increase the response rate of the family satisfaction survey by 30% in the medical surgical ICU. So upon reflection, both in my nursing practice and personal experience, it is evident that communication and engagement are essential elements of providing effective person-centered care. From working in the intensive care unit over the past few years, caring for patients who are unwell or recovering from surgery, and also engaging with families, it is important that families do care about the patient care being delivered, and they want the best care for their loved ones. So since patients may not be able to interact with the healthcare team in the intensive care environment, the family become essential members of the team. So moving on to my personal experience, I recently spent a few days as a member visiting my sister-in-law in the hospital. During this time, I gained insight into the importance of engagement between the family members and the healthcare team. For example, the doctor spoke with both my brother and I regarding the treatment of my sister-in-law. The doctors communicated clearly the test results of my sister-in-law, the condition, and the expected outcomes for her. We were provided with adequate amount of information to help in making an informed decision regarding what to do for the patient, my sister-in-law. So although communication, collaboration, and engagement were a part of this experience, the one thing missing was the ability to give feedback anonymously. So this is an ideal way for the healthcare team to optimize the patient care through making a connection with the family. So in my literature review, I found a few definitions for person-centered care. So the one I have here is one that I felt was very specific and thorough for the definition of person-centered care. And it's from the Health Innovation Network. This definition indicates patients are individuals who have specific needs and should be included with the healthcare team in the planning and discussions related to their care. So this definition elaborates further the Sunnybrook's philosophy of person-centered care, which states that the healthcare team is expected to treat patients as individuals, unique individuals. So my understanding of person-centered care is that the healthcare team members should partner with the patient and their families and treat them as experts in their individualized care through communication, collaboration, and engagement. Again, an important aspect of person-centered care is allowing the family's voice to be heard by offering them the opportunity to provide feedback through the family satisfaction survey about the care so that improvements can be made and outcomes improved. So how does this relate to my project? Well, the critical care department developed a website to partner and engage with the family members. The family satisfaction surveys are available for families to share their experience and perspectives on the care in the ICU. So the name of the survey is Family Satisfaction with Care in the Intensive Care Unit. It asks specific targeted questions related to the treatment of the patient, the pain management symptoms, nursing care, and the decision-making process. So in my literature review, I found that this particular survey was actually validated, tested to be reliable, and also used in international studies with families who have critically ill patients in the ICU. So from my literature review and research, I conclude that this family satisfaction survey is a valuable tool to collect feedback from families who have ill family members in the critical care units. So between April of 2016 last year and May 2017 this year, there's a total of 25 family satisfaction surveys collected and submitted through this link. So out of the 25 surveys received, 44% were submitted by families in the critical care unit, and only 4% were submitted through families who have family members in D4 ICU. So because there's very little submitted from D4 ICU, I'll be focusing my project in that area. D4 ICU is a small medical surgical unit. It's about 8 beds in that unit. There's also approximately 1,200 patients that come through that unit in 1 year, and that doesn't include their families. So there's a large amount of individuals that come through that unit, but we don't get we haven't received too many satisfaction surveys from that population. So I'd like to say is that the small number of surveys demonstrate there is a need to engage with families to complete the satisfaction survey. So to start off my project, I did an in-depth literature review, and I discovered through my review that technology and computer applications are being used by hospitals to engage with families and patients. As well, obtaining family perspectives on the care given to patients in the ICU is an essential measurement for assessing the quality of care. And engaging with families and patients is a strategy used to improve patient outcomes. The reference I have there on the screen indicates that the voice of the patients and families can have impact on patient or family satisfaction with care. So the next step I carried out was distributing surveys to both the staff and families in the D4 ICU unit. So the purpose for taking this step was to understand the barriers and to see what barriers are keeping them from completing the family satisfaction survey. So first I distributed the surveys online to the staff, and I also provided them with paper form. I involved the interprofessional team members. So this group included the PAAs, the PSPs, and the allied healthcare team members of the unit. So in total, I received 34 staff surveys, and on the chart illustrates that, I asked 2 questions. So I asked if they were aware of the IC website, and if they also are aware of the satisfaction survey. So in total, 48% of the staff indicate they were aware of the survey, of the website, and 56% of the staff were aware of the satisfaction survey. I also distributed surveys to the family members in D4 ICU. So far I've received 15 surveys in total. Families were also asked if they were aware of the ICU website and if they were aware of the satisfaction survey. So my initial results is 20% of the families were aware of the IC website, and 27% of the families were aware of the satisfaction survey. So on both of the surveys, I also asked what barriers were to completing the survey. And these, up on the screen, I have a list of the barriers mentioned from both the staff surveys and the family surveys. So the common surveys mentioned, the common barriers mentioned were language barriers, timing, lack of access, and being unaware of the survey and website. So the results of the survey indicate there is a lack of awareness and accessibility of the survey. So my current plan is to address both the awareness and the accessibility of the survey. One thing I was surprised about was families were interested in my project, and they made some suggestions about what I could do with increasing awareness and accessibility. So my plan is, my strategies will be to increase awareness, to distribute pamphlets, posters, put a monitor in the waiting room, and provide staff education and develop information for my new staff. And also to increase accessibility, we may provide the tablet, iPad, create a video to educate the family of how to access the website, and to put the survey in paper form in the waiting area, and have a drop-off box. To conclude, the critical care department developed the ICU website and selected a validated satisfaction survey as a strategy to engage and partner with families in the ICU here at Sunnybrook. So without the family voice, the connection between the healthcare team and the family will be broken. It is evident through my research and experience that the results of engagement and partnering with families will improve the satisfaction of care. And so I'd like to thank or acknowledge all these individuals for their support, their funding, and assistance with my project. Any questions? Okay, thank you. Oh, sorry. Sorry. You like to know on the content of the survey provided by the ICU or my survey? So my project is to increase the awareness of that survey that the critical care department put out. So I haven't actually received feedback about that survey. I received feedback about my project. I don't know if I understood your question, but okay.
Thank you, Leanne. Next, we'd like to ask Calvin Lung to come up and present. It's like it never happened.
Hello, everybody. My name is, giving you a sneak preview of my presentation. My name is Calvin Lung. I'm from the Acute Care Nursing Resource Team. And I will be talking to you about enhancing the leadership role of the wound care champion. So just a little bit of introduction on who the wound care champions are. They are registered nurses of Sunnybrook. They are unit specific. They gather up to meet 4 times a year. And the first meeting is mainly on data collection on the prevalence of pressure injuries. Sorry about that. They are led by the wound care specialist. So we're having some technical difficulties.
This has taken on a life of its own. Is that your slide? Are you using that? Or no, this is not connected. The mouse is disconnected now and it's still moving around.
All right, going back to my project. So they meet 4 times a year with one of the meetings is a half day for data collection on the prevalence of pressure injuries. They are led by the wound care specialist, and they are one of the many resources that we have for wound care in the units. So a little bit of background on wound care. Ontario spends at least $1.5 billion on wound care itself, with this cost actually expected to rise about 30% by 2020. And this is mainly due to demographic changes, life expectancy, and increasing in chronic diseases. When we talk about wounds, there's actually many causes and different types of wounds. So if a patient has a poor mobility status, what you usually would see is an increase in pressure injuries. There are chronic wounds. So someone with diabetes, they may develop like a small little wound and it'll gradually grow. So diabetic ulcer. And there's also some intentional wounds. So surgical wounds, for example. In terms of, I made a typo there. It's not wound care decreases quality of life. It's when you have a wound, it generally decreases quality of life. And common things that you would usually see is you'll see a prolonged stay in the hospital. Usually these patients are in pain, and they're usually more susceptible to infection. So, and not to mention from the patient's perspective, they look at themselves and they go, whoa, I have this hole on me, and like, I don't know if it's ever going to go away. So you can imagine how they will feel in their viewpoint. So I want to give you a little bit of the elevator speech. Imagine yourself as a fairly new nurse, and you receive your patient assignment. Okay, it's pretty good, but then you realize one of your patient has something called a negative VAC therapy. A lot of you might not know this, but it's a fairly complex dressing change where it sucks bacteria or any pus, anything out from the wound. It does take quite some time. It's a very sterile technique just to change the dressing itself. But so this nurse, usually they'll have an assignment of 4 patients. Now they have to worry about their other patients, but at the same time worry about changing this complex wound. So things you have to know is where the material are, how to change the dressing, and make sure to keep a sterile technique. For a new nurse, this could be a very stressful situation. Now that's on the nurse's perspective. Imagine the patient's perspective. They'll see the nurse, a nurse that's not confident, they show it in their body, they show it in the actions that they complete. So imagine the patient, I have a wound to worry about. Now I have to worry about how the dressing is going to be done as well. It's a very stressful situation. So let's take a step back. Imagine that this nurse knows that there's a champion in the unit, that they're approachable, that these champions are able to tell them, oh, hey, don't worry, you don't know where the resources are. I can direct you to where the resources are. I can direct you to what resources to use. And best of all, I can show you where in SunnyNet you can find the resources. Or even as simple as, if you know wound champions, they will go in with you to actually complete the dressing change if they have time. And they'll guide you step by step. Champions are there to increase the confidence of the staff, to make sure they're comfortable completing these dressing changes. So in terms of my aim statement, I want to enhance the quality improvement measures for best practice skin and wound champions. Remember, this project is about the champions themselves. What we want to do is look at what their barriers are in the units and see what we can do to increase the practice, the evidence-based practice on wound care. But why are we doing this? We want to do this because studies show that if a champion is engaged with the staff, usually this culture becomes contagious. Unit staff will become more aware of quality practices. They'll communicate with each other on wound care issues and detect for early wound care interventions to prevent further injuries. And the changes basically make everybody a wound care champion. Imagine a whole unit where everybody is willing to jump on wound care change, willing to target wound care issue preventions. So here you'll see some examples of quality improvement. Now, while all these interventions they're not applicable to Sunnybrook even by unit, it's a great example of the changes that can happen. I will be working with the wound care champion one-on-one to see what specific barriers they have in their units, or where the resources are located. Are they located at a spot where it's easy to find wound care products? And also look at the culture, the staff's approach towards wound care. So something as simple as knowing where the wound care board is it updated, would actually improve wound care practice. There's also, over here, you'll see a Braden scale. A Braden scale is something that staff use to detect for the risk of pressure injuries. Even reminding staff to, hey, remember to do your Braden scale documentation, because that you can detect patients early for their risk of a pressure injury. So currently right now, what's happening is surveys were sent out to wound care champions, this year's wound care champions and previous year's wound care champions. And we want to get their feedback and to understand their barriers, understand what we can do to help improve a wound care practice in their specific units. As I mentioned, I'll be working with the champions one-on-one to implement quality improvement interventions for their unit. Selection of this unit, so champions are volunteers. They're not forced to do this project. And prior to any intervention, we'll make sure to consult. We'll involve people, the stakeholders in this. So we'll involve the managers, the APN, make sure that whatever we are proposing for the intervention is suitable for their unit. And this will run from December up until March. So this study was actually first based from Padula 2015. And from their outcome, they saw that increasing access to the wound care champion actually increases unit satisfaction and increases the quality of wound care practice as a unit. So what you see in the first chart in the top left is if you provide the leadership interventions for the wound care champions, you'll usually see an increase in things such as prevention awareness. You'll see that they're more engaged, and you'll see more support from the managers and the APN towards quality wound care practice. The graph that you see on the top right is actually the quality improvement interventions that were applied to the unit staff themselves. Things to note here is like things such as team huddles. You'll see an increase in intervention there, and you'll see an increase in prevention education. But what you won't see is, like, for example, an all staff meeting. The improvement aren't as high. So like I said, these interventions are very unit specific. Not every intervention will work well with every unit. So that's why I want to work with the champions one-on-one to see what the culture is like in their unit. In terms of future direction, if you know the wound care champions, they are very enthusiastic about wounds. They love wounds, especially the specialists. If you provide them with more education, give them the necessary skills, knowledge, imagine what they can do for the unit. Imagine what they can bring for the unit. And with that being said, more research is actually needed to provide on wound care champions. There's not really a lot of resources out there. they're very, remember, it's like a bottom-up approach. So they're the ones who connect to the nurses who are the ones providing the quality change, the quality practices. Right now, Sunnybrook is doing a great job in terms of decreasing pressure injuries. And we want to see a continued decline on that. So we're going towards the right trend, but of course there's more changes that we can do. We can definitely benefit towards the right direction. And as an organization, it's great like to see improvement on wound care practice. So we're doing what we can to increase the quality of wound care practice. Which brings us to what this is all about. Remember, this is all about the patient's care, right? Remember, a wound care, if you have a wound care issue or if you develop some sort of a wound issue, it decreases quality of life, it increases the stay in the hospital. So it's all about the patient. If we provide the quality care, their wound will heal faster and hopefully they can go home faster. So it takes one to make a change, and it takes everybody to change a culture. So the champion, if we give them the necessary resources, they would definitely help the unit improve in terms of their wound care practices. I want to thank the PBRI Fellowship, Lisa, Sarah, for supporting me on this. Tracy, Luann, our wound care specialist, Alicia Stewart, the ACNRT manager, and of course my PBRI Wednesday group. Well, thank you. Any questions? Yes. So the question was if you see some common themes from champions, how would you proceed to provide education for, I guess, the whole group as a whole group? So first, I would like to work one-on-one. So we got a couple of volunteers. This project's still ongoing. So we got a couple of volunteers already. Once we start seeing some common themes, I'll be passing the data on to the wound care specialist. Because they only meet 4 times a year, there is a limitation in terms of how much material we can provide in the meetings. But if we see it's a prominent theme that's happening, it's definitely something that I want to bring up to the specialist, discuss, see what we can provide in terms of the meeting, provide the necessary education, provide the knowledge that would hopefully take down this barrier, or even as simple as just bringing it up during the meeting is reminding the champions. It's like, hey, remember to update your wound care board, something as simple as that, or sending out reminder emails, increasing communication, letting them know to update the wound care board, for example. So we'll target it like that. Right now, we're still working on a one-on-one theme, so unit specific. If things work out well, hopefully we'll see this expand to an organization as a whole. Any more questions? Yes. Thank you. That's a great question. So the question is how to increase the connection between wound care champions and the specialists. That's actually something that it's a bigger picture of the project. It's something that's definitely going to take more time to develop, but it's based on the early feedback. That is actually one of the most common feedback from the champions is increasing communications amongst champion and specialists. It's something that I have to discuss with the specialist in terms of what we can do to increase the communication. Obviously, we would love more meetings throughout the year, because 4 times a year is not that much. You'll imagine the gaps in between. So for now, don't have a solution for that, but in the bigger picture, that's just something that we are definitely going to be targeting at. Thank you.
Thanks, Catherine. So we're going to take a short 15-minute break, come back for 10:30 for 4 more great presentations in the afternoon or later. Okay, so next we have Aaron Kumal speaking to you. And Aaron, all right, go your neck.
Nope, that's not it. That's not it. Slide 59. And then you have some current slide. Good morning, everyone. My name is Aaron Kumal. I'm a radiation therapist, as Sarah introduced me. I work here at the Odette Cancer Center at Sunnybrook. So my project for this quality improvement fellowship is to create a care pathway for our gynecological cancer patients who receive a procedure which is called interstitial brachytherapy. So a little bit about brachytherapy. It's the combination of using a tiny radioactive source in combination with implanted needles in order to deliver a treatment dose to a target that we want directly or very close to the target. For our gynecological cancer patients who have locally advanced disease or recurrent disease, interstitial brachytherapy is a treatment option. So what this involves for the patient is to be in the operating room. They're anesthetized, they're positioned in the lithotomy position on their back, and needles are inserted in through the perineum using a template, which you see in purple on the top left slide. And the needles are guided through with ultrasound guidance most of the time. So once this procedure is finished, the patient is taken for imaging. Routinely, it's MR and then followed by CT imaging. On the right side is an axial view of a patient in the pelvis region, and the bright sparks that you see there are where the needles have been implanted. This imaging is very crucial in terms of the next step on the bottom left, which is the planning stage. The planning stage helps us delineate what the target is that we're going to treat, as well as the surrounding structures that are normal tissues that we want to spare as much as possible for this treatment. Once the treatment plan is done, the patient is brought back into the OR and treatment is delivered. The machine on the bottom right is called a flexotron, and the radioactive source is housed in that machine. And it goes in and out of that machine at the various stages of where the needles are in order to kind of conform to the target that has been planned based on the imaging earlier. And this is just day 1. So this is a kind of 2.5-day procedure altogether for the patient. And so on the second day, the patient is brought back from the floor, re-imaged, and if there are any changes to the position of the needles or based on the anatomy that you see on the re-imaging, the treatment plan can be adjusted to better conform to the target that you want to treat as a team. And if there are adjustments that are made, we'll use that new plan to treat the patient later on that afternoon. Following that second treatment, the template and the needles are removed in the OR again, and then the patient is able to go home later that night. So the thing to appreciate from this slide that I tried to kind of show is that all these things don't happen in the same physical space. So the patient is admitted the night before of their procedure. They're taken from D6 all the way here to T-wing for the needle insertion, the treatment. The MR is on the same level as the operating room, but the CT scanner is on floor below. So there's a bunch of different transfers and whatnot. And keep in mind that this template and these needles are inserted in the perineum and the patient is awake once the procedure has been finished. So that's a lot to take in for a patient. And so if I were to ask you that if this was a treatment option that you were undergoing, wouldn't you want to know this full process right from the start, right from the beginning, and have a clearer picture of what you're going to proceed through the next 3 days? So our patients are telling us that a care pathway is something that they would like to see, which shows who's going to be involved, what's going to happen to them, and most importantly, what are the approximate timelines that are going to be involved in this. So this is a long ordeal. This is 2016 data from our patient experience surveys of our gynecological cancer population. And the domains that I was very interested in are the patient satisfaction in terms of coordination and continuity of care, and information and communication, and education. And what the numbers seem to show, although the sample size is relatively small, but in terms of the types of questions that we're looking for, like if they're given enough info, if they know who to go to for questions, and if they knew the next step in their care, 60 to 69% seems all right, but that means that 30 to 35% of our patients don't have that information, or they don't know who to go to, or they don't know the next step. Similarly, I reviewed charts of patients who underwent or had undergone interstitial brachytherapy in the past, or the first 6 months of this year. And I took a look at the symptom screening that they had completed prior to their treatment, or prior to their procedure rather. And it seemed that there were elevated scores in the anxiety and the well-being questions prior to their procedure. And then also, based on the documentation, they seem to frequently ask our nursing and radiation therapy staff questions about the process, about the MRI and what that'll involve, and what medications that they should take or continue to take or hold for their OR procedure the next day, and things like that. So clearly we can do a better job of addressing these concerns up front. And finally, there's great work done by Kate Creed and our oncology program here about talking about our vision and some of the themes that came out of that discussion, which involved the Patient Family Advisory Committee and patient insights as well, in terms of coordination, and something that they brought up was supporting uncertainty and creating this patient care pathway is something that addresses this kind of need that the patients are telling us that we need to address. Our patients feel that we need this, and our staff kind of echoes that same sentiment. So in a strategy meeting in 2016, we were put into interprofessional groups and trying to outline our priorities. And it seems to be that, this is something that we can work on as a group to further excel in providing that person-centered approach to our patients, that seamless, coordinated patient experience that they're looking for to better serve our patient population. And the hope is that with increased clarity so that multidisciplinary staff that are involved in this very complicated procedure, that translates to better efficiency as well, that the patient can benefit from. And similarly, we had a brachytherapy retreat with the nurses and the radiation therapy staff earlier this year. And again, the same sentiments are echoed in this case, where if we have this patient care pathway in place, patients are better to receive, are able to receive more consistent information from everybody on the team. And then as well, the added benefit that the patients will know the next steps into their treatment, the whole course of their treatment. So again, our patients and our staff recommendations align, and so I took a look at the literature for care pathways in general, and they're very much associated with positive outcomes such as patient and process outcomes. And ultimately, what we all want is the patient satisfaction piece, and that's what the literature shows us. So this is the primary aim, is to establish the pathway in order to enhance the patient experience that is present with our interstitial gynae brachytherapy population. And I will look to measure this by looking at their worry and preparedness pre-treatment, as well as their patient satisfaction. And those are one way we're going to measure if we're doing what we're set out to do. So in terms of my project so far, I've been able to see what the care pathway literature has shown us in terms of the benefits of patient care pathways. I've seen what our patients are telling us through the chart reviews in terms of their worries and their anxieties, and the overarching patient population of gynecological cancers in terms of their patient experience that they're having so far. I've also been able to shadow some of our interprofessional colleagues, so my nursing colleagues, people in MRI, just to have a better sense of what's an ideal timeline for them, what's more realistic, what do they have to get done when the patient leaves my immediate care. I don't know what goes on that side, so it's been helpful to kind of see what the other side is like. So the next steps of my project are to implement something called the Cancer Treatment Scale Survey, just in response to what the chart audit showed us in terms of well-being and anxiety being moderately or highly scored for patients prior to their procedure. So this is a validated tool that helps to kind of measure that pre-treatment worriness and preparedness that patients feel prior to procedure. And it's been validated for radiation therapy and chemotherapy as well, so it's very specific to the oncology population. As well, I'll be involving staff in terms of getting their feedback on the pathway. And the aim is to make this collaborative as possible, so patient feedback, staff feedback, and ultimately to drive what the care pathway will look like in the future. So I plan to pilot it out, make revisions, and then have the final product sometime in March. So with that in mind, this is me kind of putting everything together. This is, things that the patients are looking for, like who's going to be involved, what to expect, and approximately how long it's going to be. I also tried to kind of show on this slide how the inpatient ward is far away from the three things in the middle, which are all in the same area, and then the CT scanner is one floor below. So is this kind of what patients are looking for, with a step-by-step kind of 1 to 4 who's involved, what's going to happen? Or is it something less of a map kind of situation, or is it more like that timeline of the slide that I had previously where it shows them what's going to happen day by day? So again, it's up in the air, and we'll see what the final product is going to be. So to conclude, so both patients and staff have identified this as a need, and so based on that, I'm going to involve both patient and staff contributions for the final product. Excuse me. And ultimately, for those who undergo interstitial brachytherapy, I want to create a pathway so that patients know the next steps, they know what to expect, and at the same time, staff to have a better view of the overall picture of everybody's role in this procedure, ultimately to drive improvements in patient experience. We have a number of people to acknowledge this, both individually and as a group, and I'd like to thank everyone on this list, maybe even a couple people that are not on this list who are here today. So thank you very much for listening. Any questions? Yes. Oh no, that would be tremendously helpful. Okay, yeah. I'll have to connect with you offline for that. Yes. That everybody's as busy as I am. There are things that it's hard to appreciate unless you're actually watching. So I feel like you think you know what other people are doing based on the outside, but while you're doing your own tasks, it's really hard to appreciate the ins and outs of what, especially the nursing staff is looking at once the patient has left the OR and into the recovery room. I'm basically staying in the OR or in the treatment planning area, so I don't know necessarily what happens or what they have to go through. So, or what the patient even has to go through at that point. So for myself, it's a greater appreciation for that, that I think was the aha moment for me. You're very welcome. Yeah, no, it's a lot. It involves a lot of people, and I haven't even mentioned, like, I want to go on the inpatient side as well, just to see what that's like, because we don't know. We send the patients there and ask them to transfer them back for imaging and treatment, and we don't know exactly what you guys go through there. So thank you for your comment.
Thanks so much, Erin. So next I'd like to call up Denise Fong.
Good morning, my name is Denise Fong. I work in the window unit. My project is on to gain knowledge, skills, and expertise in foot care and foot surveillance to prevent development of foot ulcers. Renal unit is an outpatient in-center hemodialysis unit. It has a total of 48 stations located at Sunnybrook and CNIB sites. We have a Monday, Wednesday, Friday, and a Tuesday, Thursday, Saturday group with a total of 265 clients. June 2016, we started the monthly foot assessment, which is on the third Wednesday and Thursday. We check our clients for any abnormal foot issues so that we can bring them up to the nephrologist and the podiatrist. I did a little survey on our clients, and out of these 265 clients, we had 135 clients, which is 49% with diabetes. And out of this group, there were 50 patients, which is 37% who had foot issues. They ranged from numbness, tingling or burning sensation to a loss of the protective pain sensation. Some of them have biomechanical toe or foot issues or foot ulcers. From June 2016 to June 2017, 2/3 of the people with diabetes, they die within a year post-amputation. And 85% of these amputations were preceded with a foot ulcer. The above statistics were just as what was reported by the Canadian Diabetes Association 2016. She thought that she was looking after her feet by going to a esthetician to have her nails cut and nicely painted. One morning, she woke up with a bleeding foot. She did not experience any foot pain. All she remembered was she went for her nails cut 2 days ago. She came to dialysis that morning, but by then the toe was already gray. She was admitted. A series of antibiotic and tests were done, but she needed to have her toes amputated because her wound would not heal. She was actually one of the more lucky one because she just lose a toe. She did not lose her foot or lower limb or even her life. Prevention is better than care. I believe a lot of us experience a little blister or a sore foot from wearing that very stylish, nice pair of new shoes. And a lot of us are are willing to spend a lot of money on doing facials or buying that anti-wrinkle, anti-age cream. But we never thought about buying a nice tube of cream just to massage and rub the heel of our foot to prevent that painful cracked feet. All of us have been cutting our nails and looking after our feet all our life. And people were asking, like, why do you have to tell me to spend $45 to $60 to see a foot specialist just because I'm diagnosed to have diabetes or I'm starting dialysis? Foot care is a very simple thing, but it is so crucial to prevent the development of a foot ulcer. People who have been diagnosed with diabetes or they're on dialysis, they need to know that they should stop soaking their feet because it dries up their skin. They need to wash their feet carefully and dry them, and especially between toes. They need to check to make sure that they don't have any cracks or skin breaks, blisters, or ingrown toenails. And if they do have a scratch or cut on their foot, they need to protect it. They need to clean it with warm soapy water, protect it with a protective dressing, and bring it to the attention of a medical professional. They need to trim the nails straight across and file away the sharp edges. They need to apply good lotion just to prevent cracks on the soles of their foot, to prevent, because this is a portal of source of infection. They need to wear fresh, clean socks and good fitting shoes. And if possible, wear white socks, because if they have drainage from a crack, they can see them. My project is being funded by RNAO, Advanced Clinical Practice Fellowship, which is slightly different from the TASAM. Since the beginning of the year, I have been working with the foot care best practice team and leadership to revise our monthly foot assessment forms. And now it is in the final stage, and I'm waiting for the forms committee to approve the revised form, which is basically to split the monthly assessment form into the initial and the monthly foot assessment form to make it more streamlined and relevant. And I am doing the certified foot care nurse course. I did my exam last week, and I need to do 20 case studies in order to become certified. Lessons learned. Being an on-hand nurse, hands-on nurse, I'm so used to just follow the policy and procedure to do what I need to do. Now with the fellowship, I'm learning to lead changes. And in order to follow the policy and procedure, I need to initiate something that was not there before, to set down policy and procedure, to educate the staff about the new changes. Before I started the 20 case studies, I thought it will be a breeze, because there will be more than enough clients for me to do the case studies. The college taught us to do the sterilization with chemosterilant, and I thought it will be easy. The chemicals there, I just need to sterilize the instruments. The case study involved foot assessment, health education, and foot and nail care, which involved instrument use. In order for the hospital to approve the use of chemosterilant, I need to apply for approval, which takes time, and it is not a straightforward procedure. So with back and forth consultation, telephone calls, to find out what is allowed, what is not allowed, the time frame, because the case studies are time sensitive. So lots of waiting, lots of inquiry. It involved a lot of patients, and there were anxiety and anxious waiting moments. And I'm learning to persevere. And I hope as I speak, the order of the shipment will arrive at home, and I can start the 20 case study in order to complete my my certified course. The next steps. I plan to roll out a series of staff education. The renal unit has expanded more than half compared with 10 years ago. There are lots of new staffs. I need to do a series of staff education and re-education on food assessment and the use of the revised food care assessment forms. And we have adopted the Canadian Diabetes Association patient do's and don'ts education, and we plan to make it into a pamphlet. So I need to roll out also a series of train-to-trainer to educate the patient how to look after their feet. And I plan to do before and after staff and patient survey, and to use the numbers, hopefully to make a poster presentation at the end of TASAM fellowship. For sustainability, one more. Yeah. For sustainability, I plan to continue to take courses to prepare me to become a specialized food and wound care nurse for my unit. I'd like to acknowledge these groups and individuals who have been instrumental in my proposal writing and this learning process. So thank you. Any questions? Thank you.
Thank you, Denise. Next, I'd like to call up Jennifer Wong.
So hi there, everyone. Thanks so much for coming. I am Jen Wong. Before I get into the meat of my presentation, I'd like to acknowledge the fact that although I'm the face of this fellowship, I certainly wouldn't be here if not for the support of a lot of people. And in particular, I'd like to acknowledge my co-investigation team. So Bailey Hollister, who's a social worker in the Veterans Center, and Emily McRobert, who's a social work student working with Bailey and with Monica Scanlon, another of our social workers in the Veterans Center. Now, conversations at end of life, what exactly do I mean by that? So I'm going to have you imagine for a moment a scenario. So imagine that you're a frontline clinician in whichever discipline your background is, and you're going in to visit with Mr. Jones, who you've known for a few weeks now, and who you know is nearing the end of his life. So you go in to visit Mr. Jones, and you see his daughter, let's call her Sharon, is sitting there. Again, you know Sharon. It's been a couple of weeks that you've been following him. And you just say, "Oh, hi, Sharon. How are you today?" And she looks up at you and she sighs and says, "You know, I'm okay, but I'm really tired, and I'm kind of wondering when it's going to happen. I feel like I'm just waiting." Does that make me a bad person? How would you respond in that moment? How would you feel? And so it's those kinds of conversations that we're looking to target in this particular project. And keep in mind, I should say, that it's those kinds of conversations that really lots of people on the interprofessional team can be touched by. It doesn't matter if you're the physician, the nurse, an allied health member, the person who delivers the meal trays, the person who's cleaning the room. Anyone who has a relationship with a resident or a family certainly could have those kinds of questions asked. So just to further set the context, so this project is happening in the Sunnybrook Veterans Center. For those of you who are less familiar with the Veterans Center, it's a long-term care facility. So when I say resident, I mean patient. They are residents of the Veterans Center. Our average age currently, when last I asked what the statistics is, 93.31 years. So what am I implying there? It's long-term care. So people expect that they come to live the rest of their lives with us, which as clinicians, we know that means we expect that they will die with us. At 93.31 years of age, it may not surprise you that sometimes it happens sooner rather than later. simply by age and by medical frailty. So if we know that this happens, why now? Why is this different? So the 2 units that we're targeting for this particular project, K2 Center, K2 East, anecdotally, the teams on those units, they've been saying things like, oh, you know what, it feels like the past little while, the residents, they just aren't staying as long. And the implication there is that the time from admission to death has been getting shorter. And so when I dug into the data, I found that indeed that is true. The number of deaths per year over the last few years has been rising, and the median length of stay has been decreasing. So the time from admission to death has been indeed shortening. And so the implications of that mean that staff who used to have the opportunity to form relationships with residents and their families over the course of years now sometimes have to do the same thing in months, sometimes even in weeks. So why target communication and conversation, Ella? Well, we know that in terms of quality and end-of-life care, effective communication has positive implications on the quality of care, on shared decision-making, and on patient and family satisfaction with their end-of-life care. Why target simulation? Well, it makes intuitive sense to me, and I'm hoping that it does to you as well, that sometimes with these conversations, it's not what you say, it's how you say it. And sometimes it's about the questions you ask, not about what you say. And so there's no script that we can tell people to use. There's no set checklist. It's kind of almost a way of being and a way of practicing. So simulation to me made good sense. And there is some support from the evidence, the literature base, that simulation-based education can have positive effects on learner self-ratings of communication skills at end of life. But what does a good conversation look like? Or what does a bad conversation look like? And so our team thought that to inform an education program that would actually be meaningful to our frontline staff and be functional to our frontline staff, we have to understand the lived experiences of those who have had those conversations. So for us, that means asking the staff, but also asking families who have had a loved one pass away on our units. And so in our study, we're using the term most involved person. So we don't care if it's a daughter, a niece, a spouse, a neighbor, a friend, whoever was most involved with the care of that resident, though that's who we want to ask. But in asking that seminal question, what was your experience in having conversations at end of life? That question, because of the potential for, psychological risk and some distress, is what steered our team towards seeking formal research ethics board approval. So the next couple of slides is going to speak a little bit to the thought process and the planning around that that was submitted earlier this fall. So the project as a whole is effectively a 2-phase project. The first one, as I said, is seeking to understand. So it's looking at key informant interviews of staff and of most involved persons, and using that information to map it to a somewhat modified experience-based co-design model, which I'll speak a little bit to in a moment. The second phase is kind of your classic pre-evaluation, intervention, post-evaluation. That'll be using surveys of our unit staff. So experience-based co-design, for those of you who are less familiar, this is an example that's taken from the Southwest Lens. So the emotional mapping process, effectively what we're looking to do is to hear people's narrative descriptions of their real experiences in a particular area of care. So traditionally, that can be done with a care pathway or a process map, listening for emotions and triggers to those emotions, and then seeing where opportunities for change cluster, where are their needs? Or conversely, where do positive deviances cluster? Where are some areas that we can learn from? Now, what our team thought would be really cool would be knowing that the, journey towards end of life can have a few different care permutations in terms of the number of people involved and things like that. Instead of mapping to a process map, we wanted to map to the domains of palliative care. So there's 8 domains, and so our questions are really, do concerns cluster in areas like physical care, so pain and symptom management? Are they around those existential questions like Mr. Jones's daughter asked in the spiritual care domain? We don't know, so we have to ask. And so what we want to do is, again, to see where those concerns cluster so that we can inform the simulation scenarios for our phase 2. Similarly, looking at any triggers for those emotions that come out of the interviews so that we can use those as objectives for our simulation in phase 2. So phase 2, I'm going to take this moment just to acknowledge the fact that certainly this is a quality improvement fellowship, but I have traits towards that kind of nebulous area in between quality improvement and research. But a lot of the thinking really is rooted in that iterative quality improvement thinking, even though it's not your traditional rapid cycle change. And so the example I'm going to use for that is these are all components of phase 2 that needed to be planned in order to submit to REB. And so this is all thinking that our team has already done. And in my mind, it kind of looks like parallel PDSA ramps. So these parallel systems of thinking where there's that iterative cycle of change, of hypothesis testing, and of seeking to understand. So I'll use the survey design ramp, if you will, as an example, where we started with a layer of looking at existing tools from the literature. So we use the Frommelt, which is an attitudinal scale towards end-of-life care, as well as information from the US Veterans Affairs Association's No Veteran Dies Alone program. On top of that, then the next layer was looking at the Sunnybrook interprofessional competencies. So our pre and post surveys incorporate language that is aligned with that. So language that speaks to assessments of role clarity, of shared decision-making, interprofessional values and ethics. The next layer from that, and the next question that we were asked about the survey design was, well, now how do we take the data so that people can still be anonymous, but so that we can analyze it pre-post over multiple time periods and still link the data to analyze it statistically. And so I do want to thank Sarah from PBRI for giving me a little bit of a crash course in terms of the literature base related to user-generated codes for that end. And then the last cycle for the survey design ramp would have been the usability testing, so actually pilot testing. And I had some very kind nurses on one of the other units that I work on offer to do some testing for me so that we knew that the questions we were asking made sense to the people doing the surveys and that it took the amount of time that we thought it took. So again, I just want to touch on the fact that although this has traits towards somewhat of a practice-based research, education research kind of project, a lot of the thinking still is grounded in having the end goal of quality improvement. Now, you can't talk quality improvement without talking measure. So just to give you an idea of the things that we want to measure. So as a primary outcome, we're looking at staff confidence with end-of-life conversations. So that'll be through our pre and post surveys. From a process perspective, we know that we're going to have multiple education sessions over the course of 4 to 5 weeks. So what's attendance like at one session? How can we tweak things to get attendance better the next time? Similarly, are we teaching things in a way that the objectives are met in one session? And then how can we tweak things for the next session? Balancing measures, I don't know that we'll formally assess, but some things that we're cognizant of are things like, are there more bad conversations? Are people taking more risks where perhaps they didn't used to? Or what are the implications of staff time? So those are some of the things that we're cognizant of. So that's our project to date. I'm just going to put up my acknowledgement slide. If I were to read it, I think it would read like an Academy Awards speech. So I'm going to leave it there. But I am happy to give an update in the sense that we did receive formal Research Ethics Board approval on November the 15th. So we have started the data collection process. Really excited to see where we go from there and to give you another update in March. So I'll kindly answer any questions now. Oh, sorry, you have a question. Yeah. No, great question. So we are actually hoping to target any staff on the unit. And so by any staff, we actually mean any staff. So the surveys, the only way that they're distinguished in terms of type of staff is clinical and non-clinical. So if you think about it too, I'm going to use our PAAs as an example. They're often, they're the people answering the phone if you call the unit. They're the face of the unit sometimes. So our clinical staff who don't have our same clinical background still deserve some support in terms of how to respond to the random questions that they might get. So for staff, we mean anyone. Thanks for asking. Yes. So the question was, if we're running the experience-based co-design ourselves, and then what our experiences is of them. So we're using somewhat of a modified approach in the sense that we are going to be using the emotional mapping component of that. So to inform that, we are doing narrative key informant interviews, and so those are going to be done and are in the process of recruitment right now for our social work team. So we already have at least 7 that I know of that are recruited, which is awesome considering we started this week. So we're going to be doing the interviews, and then as a team, we're going to be doing the mapping process together, and then using that to inform what exactly we're going to teach in terms of the simulation part. Does that answer the question? So yes, early stages. We haven't gotten to the real meat of it yet. We're awaiting approval, but that's where we're at.
Thank you, Jen. So I'd like to call up our last speaker, Lisa Giardino.
If you burned 50% of your body, would you not want the best rehab possible? If you were a clinician working with burns, would you not want to use techniques that took the least toll on your body? Or if you're interested in learning something new, then my project may be of interest to you. My name is Lisa Giardino. I'm a physiotherapist working at St. John's Rehab. I work in the outpatient department treating burns. My topic is called the effectiveness of myofascial release techniques in an outpatient burn population. So before I discuss my project, a little bit of background information about burns. According to the American Burn Association, 450,000 patients are hospitalized or treated in Emerge for burn care every year. Of them, 3,400 die. According to the Center of Disease Control, a third of the deaths in home occur due to burns and fire. Also, burns are the fourth most common type of trauma worldwide after traumatic car accidents, falls, and interpersonal violence. More people are surviving larger burns. So in 1965, you had a 50% chance of surviving a burn if you burned 65% of your body. Since the 1990s, you had a 50% chance of surviving a burn if you burned 81% of your body. So more people are surviving these burns, then the question then becomes how best to rehab them. For approximately the last 30 years, we've been using the same manual techniques as therapists, so scar massage, stretching, joint mobilizations. And although those techniques are effective, my question has always been, is there something we can do better? I believe the answer is yes, and I believe the answer lies in the fascia. So what is fascia anyways? Fascia is a connective tissue that connects all structures in the body, muscles, bones, blood vessels, nerves. Every single structure in the body is connected by fascia. On the left, you can see a close-up picture of the fascia, and if you can imagine arteries, nerves flowing through that fascia, that will have implications later when we talk about burn tissue. And on the right, you can see the top tissue is skin, the bottom tissue is muscle, and in between you can see the fascial connections in between the two, as well as you can see the layer of fascia that's covering the muscle underlying. So normal fascia is relaxed, it's easily stretched, and it allows one tissue to glide over top of another. Fascia forms a network, and it's like yarn in a sweater. So if you pull on one area, you can see that other areas are also affected. And on the right, you can see just the extensiveness of our fascial network. It's literally everywhere. So what happens when you get a burn? When you get a burn, the fascial layers are bound down to the tissues underlying. And this intraoperative picture shows you the depth to which tissue can be burned. It's burned right down to the muscle layer. And when it's burned down and bound down, it can bind down to the underlying tissue, like I mentioned, and cause pain, increase pressure, and reduce function. So this is a picture of a skin graft. So when you have a burn and you have a large opening, plastic surgeons will harvest skin from a different part of your area and put it on over top of the burn wound as a skin graft. And you can see here that the skin graft is bound down to the tissues underlying. So this is the lower leg, and then you can see the foot. So you can just imagine that if this person tried to move their ankle back and forth, that it would be really hard for them to do that because that tissue doesn't glide. There are different degrees of burns, and they vary depending on the depth. So the classification can occur based on the depth of the tissue burned. So on the left, you have 1st degree burn. In the middle, you have 2nd degree. And on the right, you have 3rd degree burn. 3rd degree burns down to the hair follicle. 2nd degree is the epidermis and the top part of the dermis. And the 1st degree on the left is just the top part. So that's like your sunburn. And the reason why I put this up is to show you the different classifications, but also to show you that burns are like icebergs. So what you see on the top is only part of the story. The burn scars can be bound down to varying depths along different parts of the burn. So if you have this bound down fascial tissue, what can you do? I previously mentioned scar massage, joint mobilization, and stretching. I also believe that myofascial release techniques can be used to help to release these bound down tissues. But what are myofascial release techniques anyway? They are a type of hands-on therapy that uses gentle pressure held over time on areas of tightness. And the benefit is they allow the tissue to release in their own time and in the direction that the tissue wants to release. So it's actually less painful for the patient, and I find it to be more effective, and it takes less of a toll on clinicians because they're very gentle to use. It's used successfully in the orthopedic population, but has not been used in the burn population yet. So now that we've talked about fascia and myofascial release techniques, we can talk a bit about my project. So my project is a pilot project that's looking to see what the benefits are when you introduce myofascial release techniques into the outpatient burn population. In addition, I would also like to educate staff and patients about myofascial release techniques. I have 3 goals to my project. The first goal is to increase awareness among patients of what myofascial release techniques are. The second is to increase awareness among staff. And the third is to quantify the changes that occur when you introduce myofascial release techniques into burn care. How will I do this? The first goal will be achieved through a myofascial release handout. The second goal through a myofascial release workshop conducted with staff. And the staff would be inpatients and outpatients, occupational and physiotherapists that treat burns. And the third would be using patient and clinician-based outcome measures over 8 weeks for those patients in my caseload. So what project measures would I use? I have chosen a number of different outcome measures based on the patient perspective, clinical use, and a literature review. The first one, the Vancouver SCAR scale, is a clinician-based outcome measure where the clinician would evaluate different areas of the scar, usually the parts that are the most problematic, on a scale of 0 to 14, based on the pigmentation, pliability, vascularity, and height. And so 0 would be your flat mobile scars that are pretty much normal color, and then the 14 would be your hypertrophic scars that are purple. Burn-specific health scale would be a quality of life outcome measure that the patients fill out at home, and it looks at how patients feel about their scars. So my scars are really sensitive to the sun. My scars bother me because I have to apply lotion all the time. My scars, my burn affects my ability to work, those kinds of questions. Then the third one, the patient and observer scar assessment scale, actually consists of 2 scales. One is a patient scale and one is the observer scale. And I chose this one because it asks patients to rate their pain and itchy. And pain and itchiness are the 2 biggest problems with burn scars or in burn patients, and it's not included on any of the outcome measures. The lower and the upper extremity functional scales I've included because they are good general outcome measures, and they would look at patients' ability to push, pull, carry, just your day-to-day tasks. And range of motion values would be incorporated because that's what we do as therapists. And the last two would be looking at the number of patients who received the myofascial release handout and the number of staff who attended the workshop. This is just to give you an idea of the frequency of administration of the outcome measures. So on initial assessment, week 4 and week 8, all outcome measures will be evaluated, and then goniometric or range of motion values will be done every week. Currently, I have drafted up a myofascial release handout and reviewed it with 8 patients. Then I have conducted, or I drafted a myofascial release survey and handed out to all clinicians, inpatient and outpatient OTs and PTs who treat burns, to ask them what kinds of information they would like in a workshop for myofascial release techniques, what their current knowledge is, what their current experiences are, and how long they would like a workshop to be. My next steps include discussing the myofascial release handout with staff and then proceeding towards making it a formal document for the hospital. Then establishing a syllabus for the workshop and setting a date based on the information from the myofascial release survey, and initiating data upon RAB approval. So in summary, myofascial release techniques may be helpful in the treatment of the outpatient burn population. Stay tuned for the final results. And it takes a village to raise a child, a burn team to rehab a burn patient, and it took all of these people to help me with my project. So I really thank them all for their support, and I thank you guys for your time. And stay tuned for the final results in March. Thank you. Does anybody have any questions? Thank you.
So thank you everybody for attending today. The fellows had some great presentations, and definitely I think you can see from being working frontline, we do a lot of amazing things here at Sunnybrook, but having worked frontline, the fellows definitely brought forward some ideas for innovation and how we can even continue to do things even better. So I know Grace shared with us a little bit about how pharmacy documentation can actually improve interprofessional teams. Carolyn shared a little bit about supporting patients, learning, and improving access to information. Leanne, the importance of an impact of patient engagement, so providing person-centered care. Kevin talked a little bit about championing the champions, which was amazing. Erin, care pathways and the impact on the patient experience. Denise, the impact of prevention and importance of screening and assessment overall for our patients. Jennifer, quality and end of life through enabling conversations, and how do we make that a way of being and practicing. And Lisa, new techniques and increasing awareness for impact on the patient care. So a lot of great things to come, and a lot more that we will see definitely as we move forward. So in addition to the contributions of the frontline clinicians in terms of the research and what they're bringing for quality improvement impact on patient care, I wanted to also say that not only are we developing people who have more skills for quality improvement and research, but we are definitely enabling leadership and creating leaders who will be able to help lead other people. So the fellowship team, along with their facilitators and faculty, shared with me a few words that sort of encapsulate their experience thus far, and I definitely look forward to seeing the final presentations in March, and I hope that everyone will be able to join us. So thank you very much.